Hello, everyone. I am Jillian Bartlett, and I'm the Executive Director of the Network Coordinating Office of the Primary and Integrated Healthcare Innovations Network. I am going to start us off as people are joining into the webinar. By the time we're ready for our speakers, hopefully everybody will have signed in. So this is our 2021 learning series that is hosted by the network in collaboration with different provincial and territorial sites. Today, our partner in hosting this webinar is the New Brunswick SPORE Network, and as well, we have speakers from across Canada. And so our session today is on frailty and older adults in primary healthcare in Canada. And we have a group of 3 speakers and a patient partner, Brenda Andreas from Saskatchewan, who are joining us today to present you with information. And then we will have a Q&A session. Just to let you know, you're in a webinar, so there's a few things that are a bit different about this. You have access to the chat and the Q&A box. So if there's a comment you would like to share with all attendees and panelists, if you open your chat by clicking on it, you'll see at the bottom that you have the ability to either direct comments to the panelists, or if you wish to share with everybody, you can click on panelists and attendees. These are in general comments. If you have a specific question you would like to have addressed during the Q&A session, there is a new box on the bottom of your Zoom, and it's called Q&A. So if you click on that, you can see you'll have the ability to ask a question either anonymously or with your name attached. I will be reading those questions to our panelists during the Q&A session, and everybody will answer them as appropriate. So you can put your questions there. So again, comments in the chat, questions in the Q&A box. I will be monitoring the chat, so if by chance that you make a mistake and mix them up, I will still look at questions. It's just much easier for us to do in the Q&A session. So I want to acknowledge everybody that's helped make this series possible, including Anik Baudry, who is our research coordinator, and Jamie Demore, who is our research manager for the Network Coordinating Office. I am going to thank our speakers who will be introducing themselves in advance, and Brenda for joining us today to explore this important topic. Just before we start, I am going to make a statement of acknowledgement of traditional land. This is for virtual meetings. It was developed by the Canadian College of Family Physicians Indigenous Health Working Group. So we acknowledge that the lands on which we are hosting this meeting include traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging new culturally safe relationships, and contributing to reconciliation. I do know that we have people calling in from Canada and the US. I believe this topic and what we're about to hear will be beneficial to everybody. And I look forward to a very interesting and informative and then interactive session for this webinar. We are being recorded. I will only name people in questions if they leave their name there. You can always say whether you prefer that or not in your question. So we're going to get started. Our first speakers are Kathy McGilton and Charlene Webka. God, I am sorry, Charlene. I forgot to ask for pronunciation of last names. And so any mangling of names is 100% on me and nothing to do with the person's name. So I'm going to ask Kathy and Charlene to get us started by introducing themselves and sharing their screen, and the rest of us will turn off our we'll mute ourselves and turn off our video. Please go ahead.
Thank you, Jillian, for that introduction, and thank you for inviting Charlene and I to come today to speak about our results of scoping reviews that we conducted a few years ago. And our title for our presentation is Identifying and Understanding the Health and Social Care Needs of Indigenous and Non-Indigenous Older Adults with Multiple Chronic Conditions and Their Caregivers. I'm Kathy McGilton. I'm actually a senior scientist at KITE, Toronto Rehab Institute, and also a professor at the St. Lawrence Bloomberg Faculty of Nursing, University of Toronto.
And I'm Charlene Webb-Cumagut. I'm a PhD candidate at Laurentian University, which is located in Sudbury, Ontario. And I'm from the Wikwemkong unceded territory on Manitoulin Island in northeastern Ontario. First and foremost, I would like to acknowledge my supervisor for my PhD is Dr. Jennifer Walker. She's helped contribute to this presentation as well as leading the Indigenous specific paper, as well as the funders of the project, Canadian Institute of Health Research, and the co-authors of both publications that we're presenting from today. We couldn't have done this work without you all.
Thank you. So basically, we published our protocol in 2017, and it's really a scope and review methodology of Arkansas and O'Malley, and it also is developed by Levac, Colacune, and Daunt. The 6-stage model, and I'm sure most of you are aware of this, but most importantly, I just wanted to share with you our research question, which is, what are the health and social care needs, priorities, and preferences of community-dwelling older adults with multiple chronic conditions, and those of their caregivers and healthcare providers? We were also interested in how do social and structural determinants of health, such as gender, social economic status, ethnicity, and education, impact on these needs. And I just want to tell you that when we were doing the non-Indigenous review, we used the social determinants of care model. Okay, next slide. So in the end, we actually had, because we have two different articles, we decided we would look actually at Indigenous literature and non-Indigenous literature and see what we could find and look for similarities and differences in terms of what were some of their needs and wishes. And so in terms of looking at the non-Indigenous, our flow diagram, once we actually looked at all the articles, and you can imagine we started off with 34,000, we actually ended up with 49 to be reviewed in terms of the needs of persons with multiple chronic conditions that were non-Indigenous. And then in terms of those that were Indigenous, we ended up with about 9 papers.
Primarily, we used an Indigenous Determinants of Health framework in the Indigenous specific review. So this was used to frame the analysis and results. In addition to the Determinants of Health framework, we used the International Classification of Functioning Disability and Health framework. Where appropriate, we use deductive thematic analysis on relevant extracted data to map the studies onto the domains of functioning outlined by both of these frameworks. The Indigenous Determinants of Health frameworks recognize the complexities and interconnections between the proximal, which is the crown of the tree, intermediate, which is the trunk of a tree, and the distal, which is the roots of that tree. All of these contribute to the determinants of Indigenous people's health. So the themes presented by Indigenous specific literature are accessible health services, building community capacity, improve social support networks, cultural preservation in healthcare, and wellness-based approaches. In theme 1, the need for accessible health services, we found that there are barriers in access to services that include personal, financial, organizational, and transportation, which can affect the utilization of healthcare services. For example, in financial, the cost of services, the cost of travel to get to services, and service providers' financial reward and incentives all provide certain barriers to care. We also found that equity and access, the utilization of health services depends on the affordability, physical accessibility, and acceptability of the services themselves. In the second theme, we found that building community capacity involves education, training, and support for both healthcare providers and informal family caregivers. For example, there's a need for health services and healthcare approaches which incorporate traditional Indigenous approaches to health and wellness. Overall, there's a need for formal education, training, and personal support within the communities. In theme 3, we found that there's a critical role that family members, peers, and social networks have in assisting with the management of elders' chronic conditions. There's a need to return to traditional ways of intergenerational caregiving and utilizing extended family systems, which has changed in recent years due to the breakdown of community networks and a shift in society for adult children to work in different communities. Older adults want to connect with each other and their culture and would like to see this through health promotion activities. In the fourth theme, we found that there's a need to support elders in fulfilling their cultural roles by supporting them to advocate for younger generations, educating others about health and well-being, and interacting with family, community, and the land. Healthcare providers and support personnel can build respectful relationships through improving cultural and spiritual awareness and understanding by taking cultural competency training, having humble and caring approaches, being personable and having sincere concern over the matters important to the elders, including Indigenous values of health in the service delivery and design, and respecting and honoring the different worldviews and values. Other needs include elders staying on their homelands and having trained interpreters. In the last theme, we found that there's a need for older adults and caregivers to acquire the knowledge and skills associated with implementing self-care approaches. Wellness-driven approaches to care involve Indigenous perspectives, such as holistic health that include physical, mental, emotional, spiritual, and cultural aspects of life. There's a connection to culture and spirituality, as well as social support networks and environment that show to promote balance and have a significant influence on health and wellness among aging populations.
Themes presented by non-Indigenous specific populations. We had 5 themes as well: access to information, coordination of services and supports, a real need to look at preventative maintenance and restorative strategies, training to help manage the older adults' complex conditions, and person-centered approaches. So first was really the need to access information. Older persons with multiple chronic conditions spoke about the need for more information about their medical conditions, but in terms that they could actually access and understand. The jargon got in the way, and so that was something we need to think about moving forward. And also a more comprehensive explanation of the treatment options and the rationale into why certain medications were prescribed to them was dearly needed. In terms of theme 2, we looked at our persons with multiple chronic conditions said they needed more coordination of services and supports. They really reported on this lack of a coordinated approach between services and supports, and it really impacted their daily lives. And there's the lack of coordination of services range from lack of access to specialists, long wait time for referrals, conflicting appointments, short appointments time with the family doctors when you did get them, referrals to different specialists with conflicting opinions, duplications of investigations, complicated and unresponsive services, and no opportunity to involve multiple providers in a single discussion. And given bad news like this, maybe we can change that and get multiple providers on a screen at one time. Theme 3 is really around the need for prevention, maintenance, and restorative strategies. There was a focus on dealing with the issue current, but really persons with multiple chronic conditions wanted to look at how do you prevent further deterioration of daily living? How do you maintain, function, restore any lost abilities that might have occurred, for instance, in an acute care situation? So they really focused on how do we restore lost function, because it's really rarely a focus that actually occurred. Theme 4 is really the need for training to help manage the older adults' complex conditions. So again, not only clinicians, but also staff felt there needed to be more training to help manage older adults' complex conditions and plan for the future. And actually healthcare providers even talked about learning more about polypharmacy and actually how to really reduce them, because it was a challenge. And many of our clinicians in this scoping review said that they needed more education because they needed more confidence on how to do this better. There was also a need for more psychiatric education for all healthcare professionals, because there are increasing demands to need for health, mental health promotion, and appropriate resources to offer patients. And last theme was really this idea that you need to know who I am, the need for more person-centered approaches, understand what my needs are and how they can be met, what my goals are. So we wanted older adults mentioned they wanted to be seen as a person and not merely as a number. There was ideas around perhaps more patient-centered communication and needed to be more involved in their treatment decisions. And they wanted to feel like they're being listened to. Older adults wanted to build and maintain connections and relationships with trusted providers and sought to end relationships with providers they did not trust. When we looked at similarities and differences between the non-Indigenous and Indigenous older adults, there were some similar themes between the two groups. For instance, access to information and a focus for prevention strategies and wellness approaches really were important to both our groups to help manage their conditions. Unique to the Indigenous populations was a strong focus on social support, which mostly included family involvement and the need to return to traditional ways of intergenerational caregiving. While with non-Indigenous older adults, they were concerned mainly with the coordination of services and supports. And finally, Indigenous populations were concerned with access to any services because of the remote locations where they lived and the limited time clinics were open to meet their needs. And another unique issue was really Indigenous older adults with MCC was that they had a focus on building community and the need for cultural preservation in health.
The implications for research include using the Indigenous determinants of health theoretical framework because this offers a holistic understanding and helps us recognize the importance of Indigenous values such as relationships, kinship, language, and cultural traditions and how they impact individual health. Future studies should include developing and testing integrated models of care and determining if access, information, and person-centered approaches utilizing intersectional strategies can be realized. In the healthcare sector, we need to move beyond research knowledge translation and work toward local application of these international findings. As well as gender, ethnicity, and health literacy, these are barriers to effective management of multiple chronic conditions, as non-English speaking backgrounds also led to difficulties in patient education and self-management. Implications for policy include increasing support for paid informal caregivers. Service availability varies in each community, and sometimes caregivers are required to provide the care. An option may be to provide compensation to informal caregivers for the care they provide. We need to build capacity in palliative, home, and community care, including services that are reflective of local traditional Indigenous knowledges. Funding and development of infrastructure and training programs is needed to support healthcare providers and community members. We need to understand that place and nationhood are crucial to the integrity of the relationship between nation and the healthcare sector. We also need to create opportunities for support systems. Creating social avenues enable older adults to connect with each other, their children, and their grandchildren through health promoting activities that are also culturally relevant. We also have to build an all-inclusive approach that supports an age-friendly health and social care system. So a local understanding of cultural differences is needed by healthcare providers in order to implement cultural safe multiple chronic condition care. Tailoring and coordinating services within and across sectors and considering the needs of all individuals is essential to optimizing care. We also need to look at increasing financial support for persons with multiple chronic conditions because socioeconomic status was one of the main concerns, and it was related to the older adults' ability to pay for treatments and the extra financial burden that multiple chronic conditions had on the costs of transportation, medication, and maintaining a healthy lifestyle. Translating these findings into policy will require an all-inclusive approach and will include discussions with healthcare leaders and stakeholders from local, Indigenous, and non-Indigenous organizations and communities. Here's a link to both articles, and we'd like to thank you and Miigwech for your interest in this topic.
Thank you. That is it was very helpful and excellent. I'll ask you to stop sharing your screen. And Nick will be posting these links in the chat, which will make it easier for people to access, because since they can't actually click on your presentation. That was really interesting, and I'm so pleased to see work where we're trying to promote a healthcare system that works for all of us in all of our different forms and homes and whatever it might be. So thank you. And I'm sure, just a reminder to our participants, you can put questions at any point in time in the Q&A. So as they occur to you as you're listening, please do go ahead and do that. We are going to move to our next presenter, and that is Elaine Moody, who will be talking about aging in place. So Elaine, if you want to go ahead. We still have your presenter speaker view on that slide set. This is always the fun about PowerPoints as we're trying to do this. So
yeah, sorry about that.
That's okay. We'll wait for you to share your screen. I'm going to turn myself off while you do that.
It's
Still the presenter view, but go ahead, Elena, and just go ahead with what you're going to say
okay.
as you get your slides sorted out. Okay, introduce yourself.
Sure. So I'm Elaine Moody. I'm a assistant professor in the School of Nursing at Dalhousie University. And I'll be talking about a scoping review that was done a couple of years ago and funded through the SPORE PIHCI network knowledge synthesis grant program. So we figured this out beforehand. I don't know why it's not working now, but we'll just.
Perfect. You're great to go.
Great. Thanks. So first starting off acknowledging the team. The project was, the principal investigator was Ruth Martin Meisner. She was my primary supervisor for my postdoctoral fellowship at Dalhousie, and co-led by Rebecca Ganan from McMaster University, with research team members from Dalhousie McMaster, as well as 2 patient engagement committees, one in Nova Scotia, one in Ontario, and several knowledge user partners as well. So this study kind of came about based on work done in another context that was exploring the supports needed to help older people with frailty stay in their homes. And that was a group of knowledge users, including people from private industry, from government organizations, from academia, and from and health providers. They kind of came together and realized that the out-of-pocket expenses for older people was a barrier. So they suggested we dig into the idea more explicitly through a review and see if we could identify any potential promising ways to address out-of-pocket expenses. So as others have mentioned, there has been increased focus on supporting older people to stay in the community rather than moving to long-term residential care as they experience health and functional changes. So with living in the community, there's a balance of cost between the health system and individuals. And there has been some concerns that by moving care to community, that or I guess there's been concerns that the cost would be moving from a health and societal perspective to an individual cost burden. So we're engaging with that idea that understanding individual out-of-pocket expenses contributes to decisions about where to live, contributed to healthy living environments and the ability to age well in the community. So the objective of the study was to describe the literature reporting on out-of-pocket expenses for older people with frailty and their family and friend caregivers. It was a JBI Institute scoping review. So the Joanna Briggs Institute is an organization that supports synthesis of literature for use in practice. And it was supported by engagement of older people, caregivers, and community members to ensure that findings were realistic and relevant to the experiences of those knowledge users. And that protocol is published in the JBI database of systematic reviews and implementation. So we engaged two groups of citizens. They were mostly caregivers, people who were supporting family members who were older people with frailty in both Nova Scotia and Ontario. We met roughly every 4 months for the 2 years of the project, either in person or by phone. They provided feedback on the plan for the review. We addressed or reviewed different articles throughout the process of the review. They gave feedback on preliminary findings and helped identify gaps in the literature. So to go quickly through the methods, we were looking for research papers and policy papers related to people over the age of 60 with frailty. And we adopted a really broad definition of frailty in order to be inclusive with the literature and also reflecting that frailty is a relatively new term in the literature, stemming primarily from a definition that emerged in 2001. But we kind of identified broadly frailty as multi-system impairment that contributes to vulnerability to poor outcomes and loss of function and ability to recover from illness. The concept was financial out-of-pocket expenses. So looking at expenses in contrast to income, and then looking at out-of-pocket expenses in contrast to insurance costs or health system costs. So this really was from the perspective of an individual or caregiver rather than a health system or a societal perspective on out-of-pocket expenses. And then the context was community, and we didn't look at assisted living or long-term residential care. The search strategy is fairly straightforward with JBI. There's a 3-step search process. You can see the databases that we searched here, SNEL, PubMed, etc. And then we also search for gray literature through about 30 databases, including non-profit organizations, databases of thesis and dissertations, and policy databases. So title and abstract screening and full text screening was conducted by 2 reviewers through Covidence, and then conflicts resolved by a 3rd reviewer. Data extracted also by 2 reviewers using a data extraction tool that we designed for the purpose of the project. And we then categorized and charted the findings. So here's the Prisma diagram of the inclusion and exclusion process. We started off with over 10,000 articles, and once duplicates were removed, we had 9,634, 35 unpublished sources that we got down to 42 total included sources. So again, we were open to research papers and policy papers. Ultimately, we only included 2 policy papers. Most of the studies were cross-sectional or qualitative, so the cross-sectional studies were mostly analysis of large databases collected on national or jurisdictional basis that asked questions about out-of-pocket expenses, and qualitative asked about the perspective of older people with frailty themselves, or caregivers or healthcare providers that worked with older people with frailty about their experiences of living in the community and the associated costs. So most of the studies came from the United States, 6 were from Canada, 3 the United Kingdom, a number from Asia, including 2 from Japan, as well as Taiwan and Korea. This is really important later on because we did find that the context of the research and policy papers did have a significant impact on what was studied and what implications there is coming from the research. So we categorized the findings. So we really looked at each of the papers and identified what types of expenses they either measured or identified. So the most commonly reported category was home care. So that is regulated and unregulated providers in the home providing personal care or other services related to daily functioning. Medication costs, out-of-pocket expenses associated with medication costs, that includes the cost of prescription medication, over-the-counter medication, and co-payments for medication as well. Cleaning and laundry, this was often reported separately from home care, although I suspect some of the home care overlapped with cleaning and laundry. Food and meal preparation, transportation was another big one that was mentioned in the previous presentation as well. Medical equipment, so things like hospital beds in homes. There's 2 papers related to continence, so all the medical supplies that go along with continence, oxygen, and that type of thing. Respite care, so either in residential settings, so the older person with frailty going to a long-term residential care facility or having someone come in to provide respite care for caregivers. Assistive devices, including walkers, canes, glasses, hearing aids, etc. Home modifications and renovations. This is one of the reasons why we were looking at this data or looking at these papers is considering the renovations needed to make a home reflect the needs of the individual with frailty. So there were 5 papers that talked about those home modifications, and then insurance, and that insurance was mostly related to co-payments, etc., that went along with other insurance providers. So we were really interested in exploring the evaluation of policy programs and services to see if there are anything promising that could be shared or implemented in other environments. So we did identify 2 policy papers that discussed the policy context in the US and Denmark. The paper from the US was proposing a policy change, and the paper from Denmark was outlining how the system was set up in that country to support people living at home, and they really did have few out-of-pocket expenses in that country. And then there's 7 other papers that explored programs and services. So in the US, a lot of the literature reflected out-of-pocket expenses that were incurred outside of Medicare and Medicaid. So things that weren't covered by those insurance programs, and then having kind of supplemental insurance programs that would cover these out-of-pocket expenses. So social HMOs and a voucher program In the UK context, there is 2 studies that were looking at models of rehabilitation, so different providers and different methods of providing rehabilitation between hospital and home. And then in Canada, there was 2 papers. One looked at an integrated community care program, and the other was an adult foster care program. So certainly a lot of implications for integrating care across healthcare settings, as well as across different sectors. So in terms of discussion and implications, we did find that the policy context was particularly important to what we found about out-of-pocket expenses, as is to be expected. As I mentioned, most of the research came out of the United States and explored expenses outside of Medicare and Medicaid, the publicly funded insurance programs in that country. And so certainly that has implications for national policies, but also in Canada, the UK, and Scandinavian and Asian countries looking at costs outside of the existing health insurance programs were also really important. There's also implications, policy implications for what's considered age-friendly communities. When you look at things like transportation, groceries, medication, delivery costs, etc., and how they are related to an environment, and how age-friendly policies can help to shape those experiences for older people with frailty, as well as making it easier or harder to connect with others in the community. So one important research implication coming from this study is that it might be important to conduct a policy analysis, looking at various jurisdictions and the policies that might be shaping the experience of people with frailty. So for example, in Nova Scotia, there are some programs to help support people with grants for home renovations. So whether that's a new roof or putting in a ramp, and also programs to support people who are leaving the hospital and transitioning to home, to help ensure that their house is accessible for them after their hospitalization. So there are certainly programs that are locally available, and I'm sure that's it's the case in other places. So I think it would be important as a next step to look at some of those policies, to look at the gaps, and see where what we can learn from those policies to better shape policies going forward. Also thinking about income level. A lot of policies are shaped by income, and that was one of the things that we found as well. A lot of the supports for people related to out-of-pocket expenses were for people from lower incomes, and then there was a group of people who had moderate incomes who were being missed. Thinking about quality of life and dignity, some of the out-of-pocket expenses that were identified as being important to people with frailty, but not necessarily recorded in measures of health cost, healthcare out-of-pocket expenses, were important for people with frailty. So things like pet care, dental care, vacations, participating in leisure activities that weren't necessarily identified in some of the quantitative measures. So thinking about how we can, or how we ought to think about supporting people in the community, and whether we need to consider the out-of-pocket expenses related to some of the quality of life indicators. And I think this is becoming increasingly important in the context of COVID, where people are spending more time at home without the regular social connections they have, and thinking about the ability to engage in activities that support their quality of life and potential out-of-pocket spending that goes with that. And then the last thing we found, we really didn't find a lot of literature that was looking at out-of-pocket expenses as an outcome. So there really wasn't enough literature to consider doing a further quantitative meta-analysis or a qualitative kind of synthesis of the evidence. There were several different measures used to report and measure out-of-pocket expenses. But in order to support future synthesis, it would be important to have a consistent measure.
Sorry, Elena, I don't know if you can still hear us, but we have seemed to have lost your video feed. Are you back? Okay, you froze. Yeah. So are you going to go ahead and finish up?
Oh, sorry, it's not. Sure. Okay. I'm not sure where I left off, but
Oh, Elena, you're definitely freezing. So we're gonna come. So we'll ask you to put any, like, you're right at your conclusions, I assume. So if there's anything else or any links you want us to have, we'll ask you to put that in the chat. This is the hazards of our new world. I'm always amazed when my Wi-Fi actually works for a whole webinar. So we are going to go to our last speaker before we have a few words from our, after this last speaker, Sabrina Wong, we're going to have a few words from our patient partner and move into the Q&A. So Sabrina, go ahead.
Okay. Oh, here's the video. I don't know. Anyways, yes, thanks. So that was great. A lot of work in terms of needing the combination of health and social care. So that's great. And this is a bit different presentation, but still on frailty. So this is some work that was done by myself as well as a bunch of team members. I do want to point out that the co-leads on this one are Drs. Tyler Williamson and Alan Katz, and that I'm going to talk today about a little bit about machine learning, but I am absolutely not the expert. So if you ask me any technical questions, I may not be able to answer them. I do want to point out that this was funded by the Canadian Frailty Network and also the Canadian Institute for Health Research. Okay, now, how do you get this thing to move forward?
The arrow buttons should work.
I don't see
and
it.
If not, actually on your slideshow, when you hover around it, there should be a forward button.
Weird. I don't see it. Oh, weird. Okay. Okay. Well, we'll just do that. So basically, you heard that frailty is a significant and growing issue in Canada, and it's going to affect a lot of people themselves, but also the system and caregivers. So this is some of the preliminary work that we did, where we developed a validated case definition of frailty for use in the electronic medical record data using machine learning with a data set in Alberta. And so this data set consisted of 52 clinician assessments of their patients 65 years and older, and using the Rockwood Clinical Frailty Scale. Then what we did in this preliminary work is we linked the electronic medical record data to administrative data in British Columbia and Manitoba. And we applied the EMR frailty case definition to the EMR data, and then an administrative definition, which was created by other Canadian colleagues, Urquhart et al., to the administrative data. And in this preliminary work, we examined the amount of overlap of cases in both the electronic medical record and administrative data, and the characteristics of those identified in the EMR data, the administrative data, and both. And those results are in a published paper. And basically the work showed that the EMR case definition was not awesome. And in both British Columbia and Manitoba linked data, we only identified about 1% of all cases in both the EMR and administrative data. So that's where they overlapped. For the second result, we suggested that our work provided evidence that frailty is a continuum where those identified as frail in primary care are still able to decrease their frail status or maintain their frail status in order to continue living in the community. And I think both of the presentations before me provided you with some ideas about how that might happen and the policies that we need in place for that. For the first result, we wanted to do more work with the EMR data and thought that with a larger sample size, we could increase the sensitivity, specificity, and predictive values of the EMR frailty case definition. So what did we do? We then partnered with primary care practices through the Canadian Primary Care Sentinel Surveillance Network to develop a validated case definition of frailty for the electronic medical record data using machine learning. We thought using machine learning might help us. So 5 of the 12 provincial primary care networks signed up for this project. So British Columbia, Alberta, Manitoba, Ontario, and Nova Scotia were the provinces where there are these practice-based research and learning networks. And so what we did was we had primary care physicians use the Rockwood Clinical Frailty Scale to retrospectively classify the degree of frailty observed in their patients aged 65 and above who were seen within the last 24 months. The Clinical Frailty Scale is a validated frailty measurement tool that has commonly been used in primary care and is based on short written descriptions of increasing levels of frailty. The CFS ranges from 1 to 9, with 1 being very fit and 9 being terminally ill, which is the highest degree of frailty. And for the purposes of this study, frailty was dichotomized into frail or not frail, with those receiving a score of 5 or higher on the CFS as being labeled as frail, and those with a score of 4 or lower labeled as not frail. So basically, you can read there on the slide what happened with physicians, and these data were considered, and then we extracted data as well. And these data were considered features of the EMR or characteristics data elements. They were either numeric or binary. And for example, age was considered a numeric feature, whereas various validated case definitions and chronic conditions such as COPD were considered to be binary. So yes or no for COPD as a feature. Any feature with greater than 20% missing was removed, except for height, weight, and body mass index, as these were considered to be potentially important. For these features, we conducted multivariate imputation if they had missing data. So what are some of the results? Those who were considered frail in our sample were older, mostly female, have a chronic condition, more likely to have dementia, depression, or hypertension than those rated as not frail. So that was one of the findings that we had. And you can see there that we had participation from the 5 different networks. There were a total of 90 physicians. We collected a total of 5,466 CFS scores, and we observed a prevalence of about 18%, which is similar to other reported prevalences of frailty. Okay, so in terms of this slide, it shows you there, the first column shows you that there's various machine learning techniques that we used. And we had a person on our team that knows a lot of this. And if Tyler was here, he could tell you about the differences between them. And I'm not gonna pretend to tell you that I would know the differences in very technical terms. But I will say that generally the models had poor sensitivities that ranged from 28% to 81%, while achieving higher specificities that ranged from about 53% to 95%. There was no model that distinctly demonstrated the best performance in terms of sensitivity, specificity, or predictive values. Most models were able to achieve higher than 80% specificity, and all models achieved higher than 80% negative predictive value. So what this suggests is that models had difficulty distinguishing frail patients, but comparatively were more successful at identifying people who were not frail. And in general, the feed-forward neural network had the highest reported sensitivity and the highest negative predictive value, suggesting that it could be used to identify a further subset for further analytic investigation, as the algorithm can identify patients who are unlikely to be frail with confidence, leaving the remaining patients as candidates for a more thorough frailty diagnostic test. So in summary, the EMR primary care data are now being generated widely across Canada. And there are some limitations of these data, that there's some coding heterogeneity across users. There's missing data features in the EMR itself. Some of the data are not regularly collected in the EMR data. And you heard a lot from Elaine and Kathy and Charlene about some of the work that they have done. But some of the examples are, there's nothing about housing or socioeconomic status. There's nothing about grit strength or gait speed that is regularly collected. And then there's heterogeneity across the EMR vendors. So those are some of the challenges with using the EMR data. What we found is that frailty remains a challenging concept to try to, I guess, quantify in any sort of way. And it still remains an underdeveloped concept in primary care. And there's no EMR data content standards that with regards to frailty. So people aren't necessarily recording it, which is part of our issue. But that the feed-forward neural network holds promise for decreasing those who need further assessment. So that's a good thing. And that machine learning is a tool that could be combined with clinical judgment to assess for frailty in primary care.
Okay, thank you, Sabrina. That's a really fascinating, we have one more presentation, well, not presentation, but comment, and then we'll move into the questions. I encourage you to put your questions in the question and answer. We're seeing a very interesting perspective from different areas around this notion about older people and how well we're doing with our conceptualization of health for our older and more vulnerable populations. Okay, so I am going to ask, as last but certainly not least, Brenda Andreas, who is our patient partner from Saskatchewan, to give her a few thoughts about this, and then we'll move into the Q&A. Go ahead, Brenda.
Thank you, Jill. And first of all, I would like to say how excited I was to have this opportunity today to listen and to hear about some of the research that's going on around elderly and frail elderly. I'd like to just share a little bit of my own lived experience. And I have to start with telling you that something mysterious happened to me a couple of years ago. I started getting a check in the mail and it said old age security. And that took me a moment of pause to think about, well, what does that actually mean for me personally? And today, I think I get up every morning and I remind myself this: aging is not a disease. It is both a challenge and a joy. So what does it take to maintain me, or for me to maintain myself and my community? And I need a balance. And I heard that today from each of the three presentations. I heard how important it is to be respectful and mindful of our Indigenous communities and all of our communities where our elders are considered to be special to be revered, to be respected. I also heard from Elaine about the inequities around for many older adults, particularly women who never had a checkbook, never had a job, and were always Mrs. John somebody rather than just who they are. For me, Brenda Andrews, and the challenges around the social determinants that the costs of healthcare are. And then I heard from Sabrina about how important it is to be considered of what is it actually that we need to consider from the point of care with our older adults and our frail elderly. I would like to leave you with one thing: autonomy, independence, resilience, humanity, connection, trusted relationships. Those are the things that matter to me. It's not so much that I have to go for a lot more tune-ups and medications and treatments and procedures. It's that what can I do for myself and what is important to me in that? And really what's important is I just want to be seen as a whole person. I'm grandma, I'm sister, I'm caretaker, I'm all of those things and so much more. And I'll just stop there, Jill.
Thank you, Brenda. Your perspective, as always, is very welcome. I will ask, actually, you know, all of my panelists to turn their videos back on, including your Brenda. And we are going to go to a Q&A. We do have a question already. I'm going to go to in a second. Before we answer that question, I would like, what struck me about listening to these presentations and what the pandemic has made crystal clear, hopefully, to more than just us as researchers or stakeholders in this whole process, is that health is far more than clinical visits. And it taps into far more than this healthcare system. I would just like for all of you to reflect, and I'm going to come back and give you some time to think about this while we answer the question that was posted. I'd like each of you to reflect on if we want to move into this larger notion of health, if we want to talk about dignity and aging not as a medical diagnosis, but as a part of our life. And as Brenda says, it's a privilege to age, right? So how do we optimize that, and how do we balance quality of life for everybody in terms of maximizing health? So I'm going to ask you to reflect, if we were to move into that environment, it's not if, when, let's say when, let's be optimistic and say when. What do you think is the number one thing that needs to be addressed first? So of all your work you're looking at, what would be if I said to you, guess what? I won the lottery. I won the whatever it is in the US. So now like I have $1 gazillion and I'm going to fund this. What's first? So just think about that. And we're going to go to the question. I'm going to read the question out loud because when you answer in the Q&A, only the person who asked it sees the answer. So the question was from Sandra, who asked, she was curious for the ML results. So Sabrina, this is for you. Were there specific characteristics of those who are frail but not identified due to low sensitivity? So if you want to go ahead and unmute yourself, Sabrina, and answer that.
Yeah, so we featurized a lot of the data in the electronic medical record. So we did a lot of extraction of a lot of the different data. And basically the characteristics that we found are the ones that were presented. There were no real clear patterns on any of the other features. So anything like, was there a specific medication or was there a specific lab value? No, we didn't find that. There were some regional differences, which just made us think, oh man, we need more data. So that's kind of the answer.
Okay, thank you. And there's one more question there, and then I'm going to come back to that little low. Oh, we got more questions showing up. I'm going to come back to that, easy question I posed for the rest of our panelists. So Andrew is wondering if you can, Sabrina, if you can speak to the learnings you experienced while implementing a standardized definition of frailty in the EMR. What were the barriers or facilitators that help clinicians be more aware of data quality and how they could be engaged to use frailty as a definition to flag or follow up. And this is quite interesting because one of the movements as we move to address equity, access, anti-racism is how we include social determinants of health in EMRs and actually act on them. So a lot of people, you've heard a lot of information today. If that was available, how does that get acted upon? So Sabrina, if you want to go ahead and specifically answer that question, and then I'm going to ask the other panelists to comment on how your results might be more actionable. Go ahead, Sabrina.
Yeah, I mean, I would really appreciate hearing from Charlene and Brenda, particularly on, and Elaine on the social determinants of health and what you think is necessary to be collecting in terms of frailty in the electronic medical record data. So, you know, one of the barriers is in primary care is using those scores. And that's why we used a very quick 1 minute, you know, what's your quick 1 minute assessment on the clinical frailty score. Clinicians don't like to spend time entering data with into an EMR. They want to be spending the time with the patients. And so we're trying to figure out how to balance their ability to put stuff in the EMR and then also how they spend time with patients. And so we're just kind of not there yet. And I think if we could get to a standard definition of frailty, then we could work with the EMR vendors to have those things in the EMR and have them required. But I think that is a conversation that, you know, we need to have as a community. And what are those flags? Because I don't think it's a frailty flag, yes, no. It's probably a combination of some of these things that you guys have talked about.
Okay, so I'm gonna call on Kathy first. I'm actually gonna call on all our panelists for this. Just a reminder for our webinar participants that we are not taking live questions, so please type your question in the Q&A box and I will read it out loud. So Kathy, did you want to go ahead and unmute yourself and share your thoughts?
Sure. I'm sorry, but there's a few questions you've asked. One of them was that overarching, what do we need to do differently, which, you know, I can actually absolutely speak about. You want me to speak to what does Sabrina need to include in her data moving forward to look at frailty? I'm here to tell you, I don't actually have that answer. Frailty isn't something I focus on. I'm sure if Ken Rockwood was on the line, he could tell you exactly what he thinks, or Melissa, Andrew. I know I'm working with some engineers right now trying to get at frailty within homes, but that's actually monitoring them with artificial intelligence. So, you know, they're going to be looking at things like fatigue levels. So how fatigued are you in your home? We're going to be looking at mobility status, because we know if there's a difference in your mobility, there could be some issues related to your becoming more frail over time. We're going to be looking at weight loss. We're going to be looking at nutritional status. So these are some of the constructs that actually incorporate frailty, and we might be trying to get at grip strength as well. I don't know how they easily translate into your clinical data systems. That isn't my area of research, but just to let you know, this is a universal concern that we are trying to get at. How are people becoming, how can we monitor when frailty is happening within the homes? And which is actually a different question, but I think it's actually kind of similar. What exactly are the key determinants? And what we're going to try to focus on with this PhD in engineering is try to get a sense of which of these 5 or 6 constructs are the most prevalent. So what do we really have to focus on in terms of if there is an issue in X, maybe we need to be most concerned, and perhaps it is the mobility that we have to see more sedentary in the home. So again, I don't know how to translate that into your clinical data systems, but that's kind of what we're thinking conceptually within people's homes, how to observe changes and try to link that to frailty.
Thank you, Kathy. And I think this is going to be a big issue going forward is, you know, so many things as COVID has made clear impact health beyond chronic disease, beyond medications, and there are big impacts on health. And how do we proactively address those? Charlene, did you have any thoughts you wanted to add before I switch to Elaine? And Brenda, I'm keeping you
Sure.
last but not least, as always.
Yeah, I
Go
just
ahead,
wanted to
Charlene.
I just wanted to echo on Kathy's comments. You know, the scoping review that we developed drew on a lot of qualitative research. And from that perspective, I can say that the definition of frailty can be very different between an Indigenous and non-Indigenous perspective. So I think standardizing the definition of frailty should include those voices from Indigenous communities to define that, because it might look entirely different from non-Indigenous definitions. And then you can work from that to develop that those quality assessments and how to implement it in the EMRs from there. But yeah, I think a lot of qualitative work can be done to ask older adults and their caregivers and healthcare providers on what they believe frailty actually means. So healthcare providers and clinicians can align that in their EMRs.
I think that is an excellent point, because I think that oftentimes our medical or definitions do not agree with how people perceive themselves. And it's really important, because if you're saying, hey, I'm going to help you with this problem, the person's saying, what problem?
Yeah. Yeah.
That's not a problem for me. So I think from the Indigenous for sure, but from a lot of different perspectives, and there are cultural implications and ethnic implications to frailty and frailty definitions. And if you don't want to be addressing a problem that somebody doesn't see as a problem for themselves. That's a really excellent point. And it relates back to what Kathy said. So Elena, you're more looking at the costs of some of these things, but I think that's also important. You know, we can't come up with interventions that people just simply can't afford. So what are your thoughts in terms of how this might be included?
Yeah, I think when I think about the definition of frailty, and I think about the importance of, or the need to keep people at home, or the preference to keep people at home, the big thing that comes to mind is the social aspect. And I think the other panelists have mentioned that as well. And I know that looking at some of the work I've done in collaboration with the Department of Health and Wellness here in Nova Scotia, having a caregiver was a significant preventative factor for people to move to long-term care. So if people don't have a caregiver, they're more likely to move to long-term residential care. And even in other research I've done about the experience of people living in the community with frailty, having formal or informal social connections that could provide some of that instrumental support, and you know, things that otherwise people would need to pay for. So I'm thinking like snow removal, lawn care, getting groceries, cleaning your curtains. So things that make the home habitable and support daily life can be supported through community connections. And that might not necessarily be a family member in the traditional sense, but might be a neighbor, someone who goes to the same church, or a community member. So I think that would be something important to flag. In terms of EMR, I don't know how you'd capture that. I know there's some work being done about the using the comprehensive geriatric assessment in the EMR in primary healthcare. So I don't know if you're have been part of those discussions, Sabrina, but I guess that's looking at several different data points to consider an overall picture, and using that to implement a care management plan.
Yeah. So there is something that is done in research, probably more from a sociology perspective, called social cohesion. And I think this is probably something that Indigenous communities are far more familiar with. It's just how strong your community ties are, and what the implications are for people in your community when they face any kind of challenge. So I think that, you know, we're like, okay, we're very, very, in Western medicine, we're extremely individualistic. We treat the individual, but the individual doesn't exist as an individual. They exist in context, and they exist in community, hopefully. Sometimes they don't. Sometimes they do exist in isolation, but that's rare. And so it's how do we capture that complexity and leverage it, I think is really important. So Brenda, I'm gonna go to you for your thoughts on this, and then we'll move on to the next question.
Well, Jill, you already summarized what I had written down, and this is what I wrote down. We should not expect our healthcare system to be the one-stop shopping center for our elderly people. It should be about community partnerships, and it should be about informal and formal caregiver relationships. So it's not just that little no-name grocery store out here. It's called the co-op, although you could expand that to say a cooperative collaborative with a community that covers the whole life cycle and all the care needs from the continuum of care. And I'll stop there. This has been so exciting.
Yeah, and you're fantastic at the alliteration too, Brenda. That's great. We've got another couple of questions. I just want to make a note that one of the attendees has noted that as of the first week of December, TELUS EMRs include the CFS, so that's the frailty measure. But that leads to our next question that Kate has posed, who says, once a frailty score is determined, what is done with that information? How is it utilized? So we've touched on how things we think should be taken into consideration. But again, this comes back to, just quantifying something or identifying something, that often puts the other people, so you've labeled it. And what does that mean besides potentially offending the person you're labeling because they don't want to be considered with that label? So Serena knows who some people are referring to. And so I will, Sabrina, I'm sure you've considered this, but then we can open it up as well. And then I have another question. Yeah. So Sabrina, you want to go first?
Yeah, I think, so Kate is asking about what is done with the information. And so in the particular study, what we did was we collected the frailty scores, and they stood as the standard by which then we were trying to look at the EMR data with the machine learning, right? So we then were able to use the frailty scores by the clinician assessment compared to the electronic medical record data, and then calculate sensitivity, specificity, and the predictive values. So if Ken Rockwood was here, I am sure he would say, well, it's a quick screening tool only to see if a further, more in-depth assessment would need to be done with using a comprehensive geriatric assessment tool. So it's really just sort of a twig. And in primary care, we're trying to identify who are the people that are sort of sitting between, I'd say, a 3 and a 6 on that frailty score. And then trying to figure out, okay, are there things that can be done for the person to help them maintain themselves in the home?
Okay, any other thoughts from our panelists? Kathy, go ahead.
Yeah, so I've worked with Janet Malpahaney, and she's also looked at frailty scores, especially when people are in acute care facilities. And she's been able to demonstrate how quickly you become very frail when you're a senior in acute care facilities, let alone long-term care homes. And the beauty there is it can be reversed, some of these factors. So what's important is if you do have a number, as a healthcare professional team, the importance is trying to get them back, get those skillers back up, because there are reasons why people's frailty scores can go quite a bit lower, and that's a lot to do with the decreased function that's happening in the hospitals, and also cognitive issues that result. Martine Putz and I also developed, we looked at another review looking at interventions that actually influence frailty for persons living in the community. And again, there's evidence that you can actually influence those frailty scores. So I think that's also really important, that exercise, diet, we are seeing differences. So it's not it is a score, and it is probably useful at some period in time, but it's a baseline, and we can actually modify that with, of course, we being the person that is living with frailty, with some interventions. So there is hope. And I think it's important to note those.
That's an excellent point. I think sometimes when a diagnosis is made or something's flagged, People think there's a finality about it, but even things with like diabetes, and they can be reversed. There are interventions that have been proven effective. They may not be easy. And then it's some of Elena's work has shown is, are they accessible? Can they afford it? But I think that it's important to focus on what can be done. And Juliet, as one of our attendees, has commented, so if the EMR is used as a flag for pre-frailty or frailty, then a primary healthcare system, there would be other healthcare providers who could provide a context-specific assessment and streaming to different services necessary to keep the individual living in the community. And I think that piece of the work is also where it allows for individualization and respect of different perspectives that Charlene has brought up. So, you know, what it might look like for somebody in Northern BC may not be the same thing as what it looks like for somebody downtown Toronto, but with the notion of respecting autonomy and getting people as maximizing what they want out of their life and how they want to live it. Okay, so I think that is critical, right? And this is the one thing we've tried to bring in these learning series is not only are we producing important information, but how is it actionable? How is it going to change things? How is it going to improve health and for everybody, and not necessarily in a medicalized way? Okay, so the other question we have, and actually this is for you, Brenda, but I will ask Brenda to respond and then ask the others to comment on it. And the question for you, Brenda, is from Laurette Dubé, and she's asking you, as a whole person aging elder, I may just refer to you as that title from now on. What would you suggest as a primary action item for health systems or researchers to address? Easy question, right? What's your wish list?
Well, absolutely. The wish list is that we build relationships, that we build connection, that we build that whole picture based on, I keep saying, you can't put a Band-Aid on everything. It's like COVID. Communities had to take personal accountability and responsibility. And maybe what researchers need to do is balance between being academics and clinicians, but maybe they need to be storytellers too. Like maybe they need to take that evidence-based best practices approach that we have to our healthcare system and apply that to what it means from a community perspective or of a shared relationship responsibility, but which is personal accountability, which is what we do with COVID. I don't know if that made any sense, but it's there.
Yeah, absolutely. And I think a lot of times in research, where we value objectivity and scientific truth, and because we see that as a dichotomy between more subjective things like emotions and relations and whatever, we do a disservice. And I think one of the approaches we have promoted through our network is partnered research, where the people who are impacted by your research are part of the process. And the other thing we have promoted is mixed methods. Yes, you need to know the magnitude of a problem, and yes, you need to know the potential, how what impact something can have, what size of impact. At the same time, you need to know context. You need to know the richness of that data and how it would work. So we're in the last 10 minutes. So sort of following up from what Brenda was asked, and where, how do you move? I would think that it's sort of like, this is health. What else needs to be incorporated? What other domains to make this work, and not just medical domains? And so I'm going to ask each of our panelists to take 1.5 minutes to reflect on where you think we need to go next in the research. So if I had this giant pot of money, what would you like to do? So Elena, I'm gonna pick on you first, and then we'll move to Kathy, Charlene, Sabrina, and Brenda. Go ahead.
Oh, great. So when you asked this question originally, before you got to the end of the question, I thought immediately about the social piece, and then you.
Oh, Elena, you're having Wi-Fi. Maybe turn off your video. Elena, you're having Wi-Fi issues.
Okay. Okay, and I'm far away from my router
Oh,
impacting.
okay, yeah, that's always a problem.
Can you hear me?
Yes, go ahead.
Yeah. Okay. I was just saying, you know, as you were asking the question, my initial thought was related to the social piece, and like Brenda, thinking about connection and relationships. But that's not something that we can change with money. So I think here beeping, is that someone else's computer?
No.
With the integration of services, so I think the social determinants of health clearly make a big impact, and some of those are the social pieces. But thinking about how to not look at health as its own thing, but looking at health as a wider concept and connecting it with some of the other systems, social systems. So things like housing, community services, thinking about income, thinking about social support, thinking about housing, all kind of coming together, which I know is a challenge and has been something that people have been aware of over time. So I don't have any special answers to how to do that, but you know, definitely integration of the different systems is really important. And the other piece I would say before I move on is just having a bit of time to be able to explore with individuals in a primary care context some of the social determinants. You know, doing things like the comprehensive geriatric assessment take a lot of time, but it's worth it to find out some of those things are affecting their quality of life or their health.
Okay, thank you, Aline. Charlene.
Yeah, I just wanted to draw on the like socio-ecological lens, like looking at the different levels of support an older adult can have. So, you know, at that individual and kinship level between their family and their neighbors and their caregivers, and then expanding on that to include like the community level, and not only the healthcare system, but the all systems in place in the community. And if you reflect on what the themes are in age-friendly communities that's provided by the World Health Organization, there's specific recommendations for those in rural and northern communities. And further, I think you know, more work should be done to reflect individual Indigenous communities, because there would be some pretty marked differences. And this is the work that I'm engaged in, that I'll be doing for the next few years with an individual community. But what I've seen so far in the literature is that you know, there has to be support in housing, infrastructure of the community, helping to develop more connections between the older adult and their children and grandchildren, which, you know, has been impacted by just society's shift from working in the home and close to your family to working in another community or in another city. So like really drawing on some more traditional ideas of what supporting an older adult or living with the caregiver might mean, such as intergenerational housing. So having you know, them in the home with their extended family members to provide that care for them up until you know, they get to the point where they have to go to a long-term care facility. But supporting caregivers is definitely a priority. Informal caregivers at that, because they're often unpaid and do so much work. And you know, it would be nice to see more of a focus on home and community care and palliative care in the community from our, you know, from policy makers and our, you know, government level who develop our healthcare systems.
Yeah, that's I think COVID has now given us a lot more sympathy for caregivers as people are at home trying to juggle caregiving responsibilities for young families, older family members, for everything at the same time as they're trying to work full time. And I think people have a new appreciation of exactly how much work that is and how challenging that is. So hopefully that'll be an impetus, as well as this notion that maybe we shouldn't only just be focusing on the individual, but how do we strengthen communities? How do we make communities stronger so that, you know, raise the boats by raising all the water? So I'm going to ask Kathy and Sabrina and Brenda to go very quickly. We have 5 minutes left. So Kathy, any final thoughts on this?
Yeah, I think we need to really start looking at this notion of this age-friendly system. We have to be much more integrated. I think I'm speaking on behalf of what everyone else has mentioned, and really think about access of services for some of our more senior elders. Our doors are closed often, especially when you have a cognitive impairment. We need to really rethink that. And I think the focus on maintaining independence. That's also a WHO recommendation. As we grow old gracefully, all of us want to be as independent as possible. Are there programs in place, no matter what our conditions, to do that and restore potential if it happens to get lost? Do we even have the services available? I don't think we do, and we need to start thinking more about how to do that well and making sure our families are there to support us. That's it.
Thank you. And we do have, I'm going to ask if you have a answer to this question, to put it in the comment to all attendees. Juliet is asking if there's a good conceptual model of community living for frail older adults. So if you have some links, please put it in the chat. Sabrina, go ahead.
Yeah, I mean, I would agree with everything that's said. And I specifically want to call out one, integrated health and social care. And then secondly, this idea of creating community. So you can't just have services available. You have to spend some money. So if you were to give me some of your money, I would want to create communities. And that takes infrastructure funding. It means arts and music, a vibrant community for people to live in. Unlock housing is a really good example in San Francisco. And it really brings home this idea that Charlene has been talking about, that we do need to think about these cultural aspects as well. And like food is a big deal. And it's a big deal for people. If you go into a care home and you do not eat mashed potatoes every day or whatever it is, like it's going to be not awesome for you. So I just think that, you know, some of these other things like home care, home support, the types of food, it really means that we need to be thinking about, as you said, at the community level, and then some of the cultural ways in which we live. So we're independent, we live together, but how do we meet those kinds of needs as well?
Yeah, exactly. That's a very big deal. So Brenda, last thoughts. And just before Brenda goes, I do want to draw your attention that we will be having another series coming up. It is advertised on our website. It will be in March. And to thank our funders, our primary funding source is the Canadian Institutes for Health Research. And we have many partners. It's a 50-50 partnered match. So all of these projects and all of the network has been supported by our funding partners. So Brenda, last thoughts.
I would say two things. Aging and frailty kind of sneak up on you. Where you least expect it, there you are getting a check, or you can't get out of bed, or you can't remember where you left your keys. And then more stuff happens after that. So you know what I would say to you from all of this? We need to have some education and we need to have some conversations. Have conversations with the elderly, frail in your life, in your community, about what matters to them. Do they want the mashed potatoes in the old folks' home? Or do they want what they get at home, which is maybe not a housekeeper and maybe it's not the cleanest place in the world, but it's autonomy and independence. So start those conversations and be real clear about what matters to them as individuals, and then go to your community and get some money to do it.
Seems very straightforward, Brenda. Thank you for solving all of the problems we have around this issue. I do have a lot of hope that COVID has acted as a very unpleasant lens to bring these issues to the forefront, and that maybe we can reimagine how we address them instead of repeating the same things, which we've seen with our current situation are not working well. So thank you everybody for attending. Thank you to my panelists. Very fascinating, very informative. And this will be available on the website. And I look forward to our next session, and I look forward to your ongoing research and how that can help inform our way forward. So thank you, and we will now end the session.